The study was a French PRODIGE 24 and Canadian PS6 study, a cooperative study which was done in patients with resected pancreatic cancer, and we have compared two adjuvant regimen for 6 months, gemcitabine, the standard of care, compared to modified FOLFIRINOX, and we included 493 patients in 77 centers. We have done an intent to treat analysis, and then the main results of the study is that the toxicity was higher, as presumed, with 4 drugs in the FOLFIRINOX arm, mainly diarrhea, mucositis, and food syndrome, but regrettably one toxic death occurred in the gemcitabine arm and none in the FOLFIRINOX group. Gemcitabine was responsible for more grade 3/4 thrombocytopenia, more headache, flu-like syndrome, and so on. I would like to stress the main result of a study, which is an increase in 3 years DFS, which was 21% in the gemcitabine arm and 39.6% in the FOLFIRINOX arm. This translated in a large difference in the median survival, which was 35 months in the gemcitabine group and 54.4 months in the modified FOLFIRINOX group. So we have concluded that FOLFIRINOX is more toxic, but still a safe regimen, but it increases all results and all endpoints in the study: disease-free survival, metastasis-free survival, cancer-specific survival, and overall survival. So it's a new standard of care, at least in Western countries. We should consider different strategy, because pancreatic cancer is a very aggressive tumor which progresses very rapidly, and the rate of A0 resection rate is still rather low. So the next step is to compare the perioperative treatment with a modified FOLFIRINOX. I mean pre-op and post-op, as compared to surgery alone, then adjuvant chemotherapy, and 2 trials are ongoing in Europe. We are considering radiation with chemotherapy in borderline pancreatic cancer, and also an ongoing study is ongoing in France to compare neoadjuvant chemotherapy to neoadjuvant chemotherapy, then chemoradiation as preoperative treatment.